After reviewing the medical record, it was noted that the beneficiary was admitted to home health services on February 23, 2009, following hospitalization and rehab stays. There were 2 start of care dates since October 2008 with physical therapy services. Is that news for anybody? That Medicare would go back and look into the common working file and find that we paid for this already twice, because they never did that before. So that's an element. When you get a referral in your intake department, you check and see whether they're open to anybody right now. Well, this person wasn't open to anybody right now, but they'd had 2 PT programs in the past 5 months. So Medicare's thinking what? They're thinking, well, either it worked and they were non-compliant and they lost the progression, or it didn't work and we're just trying it for the 3rd time. Everybody understand this? So, needless to say, they're thinking something else about it right at the start. They haven't even gotten into the OASIS yet, let alone the notes, and they say, wait a minute, we paid for this twice already. Then they move on. 3 skilled nursing visits were reasonable and necessary for assessment, follow-up, and education. After that, the skilled nurse provided general assessments and general education. No coverable diagnosis for the B12 injections. Uh-oh, there we go. They learned about B12 injections, and they're going to deny those. The next sentence, the therapy started 9 days after the start of care. On March 2nd, 2009, she ambulated 50 feet. At the start of care, she ambulated 100 feet with 2-wheeled walker. So somehow the nurse that did the start of care OASIS says she walks 100 feet, and then almost 10 or 11 days later, the PT came in and said, I walked your 50 feet. The physical therapy interventions were for endurance training and did not require the skills of a therapist. The documentation does not support the PT, and skilled nursing services is reasonable and necessary. 3 skilled nursing visits will be paid at the visit rate, as the payment episode for 5 visits was not met. The provider remains liable for the denials. We got this claim for this patient that before we even got started, we realized we'd paid for it twice before. And now we're getting the same claim. This could be the kind of patient that we're talking about that turns into a permanent home health patient. So we don't really want that to happen. So before we even get into finding out what happened, let's share this concept. We got our antenna up about this claim. Then we go into it and we find, oh, it's a B12 injection. There's a B12 injection on the care plan. You know what? I bet the nurse has been doing B12 injections during those other 2 sessions I paid for since October, and somebody has convinced themselves, the patient, the caregiver, the agency, the doctor, that this is a B12 injection vehicle. It's easier to call the doctor. He says, I'll order home care, and we're going to send the nurse back out again. And then the agency, this might be one of those where the agency says, well, let's try PT again because that's what pays for the B12 injections. Then the skilled nurse came in, and we couldn't get therapy out there for 9 days. Ooh, this plastic butter knife is getting duller by the second, isn't it? Because what is this? This is not a real attempt at getting somebody better. This is some sort of merry-go-round for billing. We can't even get our act together to make it look like we're serious about it by getting the PT out there the next day. Then when the PT came out, he immediately said that she was walking half as much as she was 9 days earlier. Oh, you see what this is? I mean, we could have had a 5th grader fill out these things, and they'd have done a better job of making a case for us as to why we need to pay. And then we have the therapy components in which either one of those seem like functional distances for us, 50 to 100, because you know we've been talking about 50, 75, 150, about functional components. So this didn't have a chance before we got started. That's what they think, and they're probably right on half to 3/4 of those statements, and that's enough for them. It's just business as usual. Yes, Dr. So-and-so sent a referral again about Mrs. So-and-so. Oh, she requested the same nurse and the same therapist, and send the government the bill. So you got to understand, they're reading into these notes, and they're having these, what I would call damning conclusions that they're arriving to so that they can figure out what they're paying for. So you got to understand 5 visits doesn't mean jam them in as fast as possible. Use them strategically and get done what you're going to get done. But a lot of clinicians don't want to engage the caregiver. Don't want to assure, how can I be responsible for whether they do it on Tuesday and Wednesday? You know, I've got 30 years of saying, well, I'll be responsible because I can get them to do it on Tuesday and Wednesday. So pay attention to exactly how your clinicians take this challenge on. This is a nursing one, a rare nursing one. Every now and then I'm on the phone with a larger agency, and especially the publicly traded companies. And they say this, well, we've got 21 days of observation available for nursing. I'm like, really? I'm not seeing that. So the third one, the patient started home health on March 15, 2009. A skilled nurse was ordered to see the patient for observation, assessment, and teaching regarding the patient's Metaport site. The documentation did not support that the skilled nurse visits were reasonable and necessary after March 17. So how many did the nurse make? 2. The patient's wound was not infected. There was a pinprick size opening that showed no evidence of redness, swelling, odor, or drainage. Where did they get those descriptive terms from? The OASIS? They just went to the wound section of the OASIS and told you what you didn't tell them existed. And that's why we weren't paying you. 2 visits were sufficient time to teach the patient and her mother wound care and assessment. Therefore, 2 skilled nurse visits will remain denied. The social worker visits remain denied because there was no qualifying skilled care in the home. So social work went out. The denial of the services resulted in a lower reimbursement rate because the 5-visit episode was not met. The provider is liable for the difference in the reimbursement rate. This is one of those. Let's take a look at it. This is a patient who had a Metaport site. It doesn't say it was new, so they probably had it before. When they came out of the hospital, there was nothing unusual about it. And what we saw was that the nurse ordered 4 visits. In home care, we would call that a LUPA. But she added 2 social work visits. So then it became a non-LUPA. So we think this whole vehicle was an opportunity to turn a $393 claim into a $2,100 claim. But what we did was we decreased the 2 nursing visits because they didn't seem to be necessary. You went out once, talked about it, came back again. It was still the same. We closed them then. Yeah, she made 2 more visits, but we discharged her. And then lastly, the social worker didn't even get out until the end of week 2 or the beginning of week 3. So after the 2 visits that were made by March 15th and March 17th, the social worker got out on April 2nd, denied. It's all an approach to create a billing scenario. It seemed like they were doing quite well with the mother and the daughter that got it solved in 2 visits. So that's how they look at these cases, is that they're writing their own story as a backdrop, and if your approach doesn't fit, then you get denied. So these are all HIPAA compliant. A review of the records indicated the patient started home health on February 14, 2009. She was hospitalized because of a syncope, a heart attack, and an advanced Alzheimer's disease. On admission, she lived with her daughter and walked with a walker and standby assist. Medicare covered 3 PT home visits for evaluation, treatment, and establishment of a home program. See where I got that 3 from before? You see them bail out at that 3 level of establish the program. On February 26, 12 days after, it was noted that the patient was able to walk and transfer with a walker and supervision. She was not always cooperative with her daughter, but the daughter planned on having other family members assist with the home exercise program. Also, the therapist indicated therapy would be discontinued because the attainable goals were met. The need for another visit 21 days later was not supported in the record, will not be covered. For some reason, the PT went back 21 days later. In regards to OT, 2 visits were sufficient to establish a home program for strengthening endurance exercises. The visits remained denied, and the claim is paid at a lower rate. So they paid for 2 OT visits and 3 PT visits. Right, and they probably provided 15 to 16 visits the way it looks like. So, again, hopefully this will give you a little backdrop about what we're talking to and about what they're paying, and they're eventually going to get everywhere in the U.S. So, but stop and think about this. I think this is the first time I've said this. Look at these things and imagine an area where you liked that you only had to make 3 visits because you got paid for 7. So as you're reading this, think about visits disconnected from reimbursement. And you'll go, wow, great. We got that one done in 3? Great. Because, and I would say this to you because you deal with so many therapists. Think about the earthquake that's going to happen in Southern California, if not all of home care across America, when you tell therapists that less is better, they're going to be like reformed smokers. 2 visits. I got them done in 2 visits. It's the same people who said I got to have 23 visits last month are going to tell you, watch this, I'll get them done in 3 visits. So that you got to understand what's coming, and that's what all of these changes are, is a trip to that sort of approach, which is less is better. Who can get the patient connected, and that means you got to show up.